Hi, everyone. Thanks for coming this afternoon. I think we're going to have to just accept that the door is going to open and close a few times because I know a lot of you went to the 10th floor, so sorry about that. I apologize on the behalf of the building designers for the silly numbering system here. So I'm Kim McGrail, and I'm from the Center for Health Services and Policy Research, and it's my pleasure today to introduce our speaker. Before I do that, though, I just want to say thank you, a big thank you to all of the people who helped organize and sponsor this event, starting with the Canadian Doctors for Medicare, who was actually the organization that let us know that Danielle would be in town and offered that we might be able to organize this session, so that's fantastic. In addition to that, we have the BC Health Coalition, the Broadbent Institute, Canadian Centre for Policy Alternatives, C2E2, the Centre for Clinical Epidemiology and Evaluation, and of course CHESPR, the Center for Health Services and Policy Research. And I should say as well, Danielle's home institution and Women's College Hospital. So just to give you a very few words about Danielle, who many of you maybe already know, but she's a practicing family physician. She is trained in public policy. She is a fierce advocate for public health care, but more importantly for improving the public health care system. She's a clinical and policy educator and really is tireless, as far as I can tell, in anything that she takes on. She is incisive in her analysis and to the point with great calm, making, I think, other people squirm in their seats. And if you need evidence of that, you go to Google and YouTube Danielle Martin and Senate United States, and you'll have a pleasure of seeing her perform in front of a senatorial audience. So Danielle has been given several awards, one of which is a person to watch. So for those of you who've heard her speak before, you'll understand why that award was given, but for those of you who haven't, it's my pleasure now to introduce Danielle Martin.
Thank you. Thanks so much, Kim. I'll turn this off. Okay. So thank you all for coming, and thanks to the many organizations and academic departments who co-sponsored this talk today. I think this is the kind of partnership, actually, that I'm going to be discussing today. I think we're going to need a lot more of this partnership between the world of academics and the world of think tanks, advocates, and civil society if we're going to make positive change in healthcare. And in fact, that's really the thesis of my talk today. So I'm here today because it's my view that Canadian Medicare, which is, as you know, a revered social institution in our nation, of which we are wildly proud as a country, is ready for an update. And it seems to me that if we want to live up to what I call the promise of Medicare, a promise which in my view is fundamentally about equitable access to high-quality healthcare services, we have a lot of work to do. You all know that we face a convergence of challenges, a challenge of demography, an aging population, a challenge of infrastructure, a healthcare system built around acute care and hospitals in trying to respond to the new reality of complex chronic disease in the community, and I think also a challenge to our commitment, concerns that we keep hearing raised in the media around whether the system is sustainable or whether it will be able to deliver for us when we really need it. In order to live up to the promise of Medicare, it seems to me that we're actually going to have to make some pretty big, bold, structural changes to our systems in order to advance those principles of equity, equality, and access. And in order to accomplish that kind of change, we're going to have to bring both evidence and our values to the table. So my goal today is to talk to you not about the specifics of the range of changes that I think need to be made. I've been talking a lot about the substance of some of those changes in other talks in these last couple of days in Vancouver, but rather to talk a little bit about what does it take to change policy on that scale. It's my view that researchers and advocates have got to learn new ways of working together and alongside the so-called political stream or politicians in order to usher in the right policies at the right times, which is why I entitled my talk today, Bringing the Ivory Tower on Main Street, because really I think we're at a stage now where if we want to make real change, we're going to have to bring the picket line and the ivory tower together in order to create new kinds of windows of opportunity that policymakers can take advantage of. So I think the fact that a partnership is needed between researchers and advocates is required is not a big surprise to most of you. And in fact, I know that many people in this room are already engaged in that kind of work. But as an observer of sort of progressive movements in healthcare over the last decade in Canada, I would say that it's my impression that the partnerships that we do see coalescing tend to often be pretty haphazard, and they're not necessarily particularly intentional. And they're not always very explicit about the kind of change that we want to accomplish. So what I'm going to offer up today, and this is a new thing for me, welcome, is a little bit of an academic framework for thinking about the interplay between evidence or research and advocacy in achieving policy change. And I'm going to make the case for real intentionality and directionality for that collaboration using a case study or an example about a policy whose time in the spotlight I think is long overdue, which is Pharmacare. So why do I think that Pharmacare should be our target policy as a community of researchers and advocates? I'm going to just take a couple of brief moments to make the case for you. I believe that this is probably the most important policy change that we can make at the level of healthcare provision to enhance equity of health outcomes in Canada today. As all of you know, at the time that Medicare was developed in the 1950s and 60s, and even into the 1980s with the passage of the Canada Health Act, the bulk of healthcare was provided by doctors and in hospitals, which meant that our public healthcare system actually did cover most drugs because most drugs were given to patients in the hospital. But today, with our healthcare systems rapidly transforming to meet the needs of a population living longer with chronic disease, and doing so not in hospital but in the community, we need to increasingly recognize that one of the mainstays of treating chronic disease is prescription medicine. Increasing rates of diabetes, heart disease, hypertension are driving up utilization of prescription drugs, with half of Canadian adults reporting that they take at least one prescription medication, and approximately 15% saying that they take 4 or more. Yet, as I think probably most of you know, Canada today is the only developed country on earth with universal health insurance that doesn't include prescription drugs. And as I'm going to outline in more detail later on, bringing drug coverage under Medicare makes ethical, medical, and economic sense. But here's the reality. What I've just said to you, we've been saying for 20 years. And we've been saying it's an idea whose time has come for over 2 decades in a whole bunch of different venues, and that message has been coming from a whole bunch of different locations across civil society. And yet, in some ways, we are not really very much closer to seeing it implemented than we were a generation ago. So I want to say at the outset that I don't underestimate the extremely difficult task of changing policy. But it's not as though in that span of 2 decades we haven't seen other policy change accomplished. And so when we think a little bit about what is the collaboration that advocates and researchers or evidence and advocacy can have, I think it is useful sometimes to look outside of our own realm at other examples of successful implemented policy change to see whether we can learn any lessons. So I'm going to propose that we learn from actually an example of what I view to be pretty radical policy change in the area of mental health, which is the At-Home Chez Soi program, which I suspect most people in the room are quite familiar with. The At-Home Chez Soi program is an approach to mental health based on the principle of what's called housing first, which adopts the position that the most important and primary need for people who are homeless and living with mental illness is to get them housing, and that any other issues that a person is living with can only be tackled once that individual is in stable, permanent housing. By finding the right living accommodation for hundreds of people who'd been living with chronic mental illness and were homeless or underhoused, At-Home Chez Soi here in Vancouver has led to some very impressive outcomes for people with mental illness. Now, I understand that there have been controversies around the implementation of Chez Soi in Vancouver, and I'm not here to debate the details of that implementation, even if it had been a complete failure. The point that I want to make today is it happened. And it actually happened quite rapidly on a scale of policy change. So what was it that made a program like this come to fruition, which is now being scaled up in 61 communities across Canada, while policy on so many other good ideas like Pharmacare sits idle? One way for us to think about policy change and how it gets made, and how it gets made is to use a framework. And so I've actually drawn from the political science literature on this a little bit to try to understand how change happens. And some of you may be familiar with the work of John Kingdon, who wrote a seminal work on this topic of how policy windows get created and change happens in the world of health and social policy. So it's called the Policy Streams Framework, and we're going to use this framework over the course of the next half hour or so to take a look at what happened in At Home Chez Soi and what lessons we might be able to learn for trying to implement change when it comes to Pharmacare. So the basics of the Kingdom model are as follows. He talks about there being 3 streams. The first is the problem stream, which requires a well-defined problem. We're going to go through each of these in some more detail. The second is the policy stream or the solution stream, so a policy or a solution that matches the problem that's being articulated. And the third is the political stream, which has to do with aligning interests. And what Kingdon essentially says in his analysis is when these 3 streams align, a window of opportunity for change opens. And it's not going to stay open forever, but if you have the right entrepreneur in place at that moment when the window of opportunity opens, that entrepreneur, whether it's an individual or an institution, can sort of heave that policy change through the window of opportunity, and that's how change happens. So let's take a look just briefly, and I use the At Home Chez Soi simply as an example to illustrate this model. We're going to apply it and see what we can learn. So in principle, you would think that a program that essentially involves giving housing to people who are chronically homeless and mentally ill should have been difficult to implement in a short period of time. But leading up to the 2010 Winter Olympics here in Vancouver, and Vancouver was about to be on the world stage for all to see, these 3 streams aligned, and a team of researchers and advocates, where I would argue were able to create a policy window and affect change. So how did it happen? Now, probably there are some people in the audience who know this story better than I do because I wasn't living in Vancouver at the time. But actually, this has been analyzed by academics to try to understand how it was, how it came to be so successful. And there's a really good paper by Eric McNaughton and colleagues here in Vancouver. If any of you are interested, you can read about it. And this is sort of how they tell the story. So the downtown east side, as you know, is viewed as often referred to as Canada's poorest postal code. And the issue of homelessness really leapt to the top of the agenda around the time of the Olympic Games. Thousands of visitors were about to descend on your city, and that was going to create a whole host of challenges, both institutional and structural for people who were living in that community, and also, frankly, in terms of not making Canada look so great on the international stage. So for at that moment in time leading into the Olympic Games, the political stream became interested in this issue of chronic homelessness in the downtown east side of Vancouver. And that was the direct result of the Olympics coming up. So amidst growing media attention around this issue, and in response to vocal advocacy on the part of a lot of groups, some of which are sitting in this room today, your then mayor, I think his name was Sam Sullivan, someone can correct me if I'm wrong, made a public statement, and he linked homelessness and mental illness in that statement with respect to the downtown east side. And what that did was define the problem. So all of a sudden, Canadians who had not necessarily ever linked these 2 things so explicitly in their mind understood homelessness to be a mental health problem and mental illness to be a housing problem. And it was that clarity of problem definition, along with the alignment of the political stream, that allowed the federal government to turn to a team of researchers and say, what are we going to do about this? We've got a desire to do something, and we've got a problem. We finally understand these 2 issues to be linked. So they had a well-defined solution and a well-defined problem, and what the research community came to them with was the evidence around housing first. And they said, here's the evidence is don't worry about treatment teams and getting people on their medications first. Don't worry about whether or not they're sober or whether they're on drugs or off drugs. Get them housing, and once you do that, a lot of the other stuff will fall into place. And here's the evidence in support of that perspective. And at that moment in time, the federal government turned to Michael Kirby, who you all know, who's among other things, was the chair of the Mental Health Commission of Canada, and who was a well-respected person by government at that time. And he was able to function as what Kingdon would have called a policy entrepreneur in order to help seal that deal. So it really was an example of very rapid change and quick and coordinated policy making to achieve a change in policy on a scale that I think many of us might have thought wasn't possible in the decade leading up to that. So what can we learn from the interaction of advocates and researchers in framing a problem, proposing a solution, creating political alignment, and facilitating change in at-home chez soi that we can apply to this issue of Pharmacare? Given the strength of the policy case for Pharmacare, you would think it should be a no-brainer. But as I've said, we've been sitting here for 2 decades, virtually having the same conversation. And I actually think that it's possible, and I'd be interested in some of the Q&A and discussion later on to discuss whether people perceive that actually we have had true windows of opportunity that have opened and closed over the course of the last 25 years on Pharmacare, or whether we've never really had an actual alignment of all 3 streams. If you look at the history of attention to national pharmacare on a political level in Canada, we see consistent interest and consistent lack of action. Just as an example, the federal government, as some of you may know, hosted a conference on national approaches to pharmacare in Saskatchewan in 1998. So pharmaceutical reform was also addressed in the Romano Report of 2002, and in 2004, some of you may remember the meeting of the Council of the Federation in Niagara-on-the-Lake. All the premiers stood up and collectively called on the federal government to essentially upload Pharmacare to the federal level, and yet still nothing changed. And then in 2004, when the Health Accord was passed, we saw talk of a national pharmaceutical strategy, but as the Health Council of Canada observed over many reports, nothing happened there. So it hasn't been about a lack of conversation or a lack of understanding among policy elites that this is an issue, but there's been absolute inertia. So the question is why? And I think, the sort of knee-jerk reflex reaction to that question when you hear this conversation happening in corridors is, well, it's a lack of political will. So we kind of slough off responsibility onto the federal government and say, well, it's got to be about the party in power. But I don't actually think that analysis gets us very far. For starters, we've had governments come and go of different political stripes over that period of time. And I actually think if we use the Kingdom framework to help us to understand where some of the holdup may be, it gets us a lot farther than simply just saying, well, the case has been made and the problem is government's not listening. So I'm going to take each of these streams and talk a little bit about whether evidence and advocacy have really truly been fully brought into service in each of these 3 streams to see whether we might be able to advance the agenda for national pharmacare in Canada. So the problem. Let's reflect a little bit on the problem stream with respect to Pharmacare. This stream refers to how well the exact problem being addressed has been understood and articulated, paving the way for concrete policy change. As we saw with at-home chez soi, homelessness was the problem leading up to the 2010 Olympic Games, and in that case it was explicitly defined as being caused in part by mental illness, which painted the issue of homelessness really as being a problem around mental health, which you then had to address before the burning issue of homelessness could really be resolved. Identifying the problem correctly and clearly is what everybody in management speak now refers to as the burning platform, right? Why is this a critical issue? Why is it the issue that we need to address now? Why is it the issue that we need to address ahead of other important issues that are all competing for the attention of policymakers? So I guess I would ask, how have we defined the problem around pharmaceutical policy in Canada, and have we done a good enough job, and I say we as a community of researchers, advocates, civil society interested in improving Medicare, have we done a good enough job of defining the problem stream in a way that motivates policy change? So I'm going to take a look at a couple of arguments that position the lack of national pharmacare as a problem that demands policy solutions. So this is how we see the problem framed in sort of common discourse. One of 3 ways. The first is as a problem of equity. So shamefully, we know that 1 in 10 Canadians does not fill a prescription or take their medication as prescribed because of concerns about costs. And in fact, in BC, that number is even higher. I understand it's at 17%, which is the highest rate of non-adherence due to costs in the country. There are people who stand to suffer unnecessary complications of their illnesses and chronic conditions because they simply can't afford to pay for their medications. So this frames the problem, the Pharmacare problem, as one of morals or values. We should be morally compelled to provide equitable access to medications, particularly to those in greatest need, but to everybody across the whole population. So that's a really important and compelling statement of a problem. But it's only one way of framing it. The second way we've seen the problem defined is as an economic issue. If we were to adopt Pharmacare, we would actually save money as a country. So there are two major reasons for this, issues that you probably all heard articulated. The first is that in Canada, we pay much higher prices for our drugs than other healthcare systems, in particular our generic drugs. If we could negotiate better prices like those paid for in other developed countries, we could easily cover the cost of many, if not most, medications for all Canadians within our current public budgets. So just as an example, here in BC, a single 10 milligram pill of the cholesterol-lowering medication simvastatin currently goes for 36 cents. The exact same pill in New Zealand goes for less than a penny. And this is in spite of the fact that, by the way, BC has really been a leader nationally in terms of trying to push down the prices of generics. But the reality is, if we bargained harder across the provinces and together collectively, the prices we pay, even for those drugs we already buy publicly, for example, for all seniors, would go down. Second, other systems achieve these huge savings by bulk purchasing their prescription drugs. So just as we all know, it is cheaper to buy your toilet paper in those 36-roll things than it is to go and buy it at the corner store 2 rolls at a time. It is equally less expensive if you purchase if you leverage your collective buying power and achieve economies of scale. So with so many payers buying prescription drugs across the country, we are missing out on that purchasing power that would really drive the cost of pharmaceuticals down. This is then a monetary or an economic argument and an economic framing of the problem. Recent work done by Steve Morgan, who's in the room, and Jamie Daw and others looking at newspaper coverage of Pharmacare suggests that the problem has largely in the media been framed as an economic issue in the public domain over the last 20 years. But I think we have to pause and ask ourselves, if that's the case, are we sure that that's the most effective framing of the problem? Is there some better way to frame it in order to kind of capture the public imagination and rally support? The third way that the problem can be defined is as a problem of quality. Creating a coordinated national approach to deciding which drugs we're going to use and purchasing them together can help to ensure that only necessary and appropriate medications are being prescribed to Canadian patients. So this speaks to the way in which national Pharmacare and a shared national formulary across the country should be used to drive higher quality prescribing among physicians and other prescribing healthcare professionals. And it's about moving our work into the area of best practices and evidence-based prescribing and using Pharmacare essentially as a tool, one tool for doing that. So that is really a framing around a focus of quality or quality and public safety as the problem that it is that we need to fix. So I guess the question I'm asking is, what is the problem we're trying to solve here? And as you start to kind of parse out the different arguments that are being made, and I'm, as guilty as anyone, I'm out there making all of these arguments all the time. But when we do it this way, you have to ask yourself, are we trying to solve an equity problem? Canadians are dying because of a lack of access to needed medication, or are we having an economic problem, which is that Canadians are being ripped off by the pharmaceutical industry and need to get better prices on our medications? Or do we have a quality problem that Canadians are dying because of poor prescribing choices? And we may have all those problems. In fact, I think we probably do have all of those problems. And it may be that Pharmacare would fix all of those problems. But I think that when we use Kingdon's model as a way of analyzing the work that we're doing, we come to understand that it's possible that without a single clear statement of the problem we are trying to solve, Pharmacare risks coming off as a solution in search of a problem. And that may be part of the issue that we're having in trying to advance the agenda. So as Catherine Booth, another a person here from UBC and who works with the group at CHISPR suggested in a recent paper, if you don't have a single, what she calls a principal idea motivating policy change, then public demand for attention to the issue will remain low. And when public attention is low, political attention is low, which leads us into a conversation about some of the other streams. So I actually think that if we're going to bring about change, clarity in the problem we're proposing to solve is really important. And that point is very related to how we are going to articulate the next stream. So the work of, I'll just pause on this for a second to talk about the work of researchers and the work of advocates in this problem definition space. The work of researchers at some level, I would propose, is about helping us to define the contours of the problem. But if you don't have advocates in there helping to take the temperature of the public, helping to determine which formulation of the problem is most likely to gain traction in the public eye and among policymakers, you're never going to achieve success. So it's actually my view that researchers and advocates need to be explicit about agreeing together what the problem is that we're trying to solve, getting a common definition together, and then going after it. And I want to make note that I'm not actually arguing for any particular problem formulation here today. I think we could have a really interesting conversation about which one we're going to pick. My point is simply that as a movement, we're going to probably need to pick a lane. So let's talk a little bit about the Kingdom's policy stream then, or what I call the solution stream. So, you've got a well-defined problem. You now need a solution that you can match to that problem. It's about specificity. And again, clarity here is really key. When we look to the solutions that have been offered up in the conversation about Pharmacare, we find really a potpourri of options. You could have catastrophic coverage, you could have low-income benefits, you could have universal coverage with high co-payments, you could have mandated private coverage, you could have a limited national formulary, and of course you could have universal first dollar national coverage. So I want to make two key points about the policy solutions we articulate, or we see articulated in the Pharmacare debate. First, I think that sometimes in our efforts to advocate for change, and I think we all, I include myself in this, we can become so captivated by a favored solution that we risk losing the grip on the problem that we are actually trying to solve. So for example, if you start with an argument about health equity in support of national Pharmacare, then you might argue that a universal first dollar coverage plan is the best way to go about solving that problem. It's the solution that best matches that particular problem formulation. But of course, those of us who support national Pharmacare can sometimes get a little slippery. Because when somebody comes forward with an alternative proposal that might help us to achieve or get closer to achieving the equity framework that doesn't resemble the solution that we were hoping for, the response that they're going to get from us is, oh, but yes, but that won't address the quality issue, or that won't address the economic issue. And again, that may be very well true, but I think that we lose credibility and we lose momentum, when we're not able to clearly align the solution stream with the problem stream under discussion. So again, I'm emphasizing the crucial link between a focused, singular problem statement and clear links to policy solutions. The second point I want to make about this particular stream is that I think we have to understand the difference between advocating for the great policy leap versus the incremental change. Sometimes, like a new pair of shoes, I'm wearing new shoes today, I'm really feeling them, it takes time as stakeholders to kind of acclimatize to the proposed solutions. So in some instances, small steps towards the place where you want to go, rather than fighting tooth and nail, makes sense. You should probably start with the 1-inch heel and work your way up to the 4-inch heel. But other times, for some policy issues, we have to accept, as the Institute of Medicine has said, that you actually can't leap a chasm in 2 jumps. Sometimes we need to be brave and we need to be bold, and there isn't any place for incrementalism. And so I think that when you consider what the policy stream or the solution stream is that you're putting forward, you need to be clear about whether or not this is the kind of problem for which an incremental solution is advisable or not. And that's the art of it, right? Because knowing when incrementalism will work and when it won't is a tricky determination to make. And I don't actually think that researchers can do that alone, and I don't think that advocates can do it alone either. You need both those skill sets. Because ultimately, when you get that right, it leads you very well into the politics stream, which is the kingdom's final stream. So I don't think it's any surprise to anybody that politics are important when you're talking about making change in policy. And to merit the use of political capital that is required to make a big move on Pharmacare or really any other health or social policy, the policy needs to solve more political problems than it creates. I just want to pause to say that I don't believe that the existence of a political stream should be viewed as some kind of a hindrance to good policy making. The political stream is a reflection of the fact that we live in an electoral democracy. And the people we vote for actually have a role to play in helping to determine where we want our society to go. And so, it's the job of politicians and policymakers who report to them to understand what is possible, what is feasible, what is acceptable to voters. And, sometimes we are critical of politicians for having a short-term view or not being able to kind of make the difficult decision. But in fact, I'm not sure that we would want to live in a world where the mind of the electorate gets ignored by the people in political power. And so I think that rather than pushing back against the political stream as being inappropriate input to policy, we are probably better off to accept that it is in a democracy a necessary input to policy and figure out how we can work with it. So when we offer an analysis of the political stream, obviously the thing that we talk most about is interests. And the Kingdon model suggests that in this stream, what you should do is emphasize the alignment of interests of those in positions of power with the problem and its proposed solutions. In other words, the problem to be addressed and the solution to address it need to fit within the interests of those who would sway the policy process one way or another. And one great example of this is, I always think, is the fact that the policy on maternity leave, 1 year maternity leave access to EI benefits, was passed at a time that Preston Manning was the leader of the opposition, right? And in order to align that very important and very significant policy change, it was critically important that this policy solution was able to be framed as a family values thing, right? And so I think it really is important to think creatively about how one can frame solutions in order to align with the interests of everybody who's playing in that field. So it's easy to claim that a lack of political will has held up the process of advancing pharmaceutical policy in Canada. But remember that this political stream isn't just about governments or elected politicians. It's about all the big interests at play. So in this instance, we're talking about third-party payers, private insurers, unions, corporations, the provinces, and others, each of which has an interest in shifting pharmaceutical policy in one direction or another. So developing policy solutions that might potentially be seen acceptable by all those stakeholders involved in pharmaceutical policy is a pretty daunting task. But I think actually that if we don't take that on, we're going to end up with a lot of really terrific research evidence that isn't going to take us where we need to go. And it's not going to we're not going to create change if we can't frame that, unfortunately or fortunately, the reality is if we can't figure out how to frame this issue in a way that's acceptable to the majority governing party, we're probably not going to be able to deliver. So I'm going to pause for a moment to point out, and I say this because I anticipate some of the discomfort around this. I'm not saying we always have to bow to interests in order to make change happen. The political stream is not about always scoping small or scoping to the interests of the governing party. But it is about figuring out how do you find the allies that you need in order to overcome the predictable opposition or find a frame that neutralizes that opposition from the heavy interests that are involved in a particular policy area. And this is an area where I actually think that researchers can help advocates think more broadly about who our allies might be. Because one of the great skills of researchers is to be able to take a problem apart into its component parts and try to figure out what all the influences at play there. And I think that those of us who've been involved in advocacy work sometimes keep going back to the same allies over and over again. And so I think while it's important to maintain existing partnerships, looking outside those partnerships and engaging other potential allies is a critically important thing in aligning the political stream. Because if you get those allies in play, that's how you create the groundswell of political support, which helps to align the political decision makers with the solution that you've proposed. So this is why understanding how to frame the evidence in ways that can be heard by politicians who have to adhere to their party platforms, that's their job, and meet the needs of the other stakeholders involved is critically important. So it's not just about evidence, and it's not just about advocacy. This points pretty much to the need for collaboration. So far, what I've described to you is that these are the three streams that have to converge for a window of opportunity to open, whether it's on Pharmacare or any other major social policy change. Without a policy window, even a small opening, there can't be a change. There cannot be a limited national formulary, there cannot be first dollar universal pharmaceutical coverage. So the task before us is clear. We have to make the streams align. So the question is, what skills do we need to make that happen? I think that finding the policy window requires an understanding of mandates, opportunities, and stakeholders. Identifying the policy that will fit that window requires us to define the relevant aspect of the problem clearly using data and identify solutions that will work based on evidence and that fit with the political opportunity at a moment in time. So this is evidence and advocacy at the crossroads. I don't actually think we can expect any individual to have that skill set. I think that what we're looking at actually is an era where you're going to need a team. And just as the world of research has evolved over time from the days when the knowledge translation plan was something that you kind of tacked on at the end after you'd finished publishing the paper and figured out how to send out a message saying that the research had been done, to actually being considered from the very outset of the formulation of the research question. Similarly, in the area of policy change regarding Pharmacare or any other health or social policy, I think that those partnerships need to be established from the outset. And I do not think that that infringes on the critical importance of academic freedom. I think that it allows us to come forward with research that is relevant in the real world and advocacy that is informed by the best available evidence. So, Kingdon said back in 1984 that the role of policy entrepreneurs was critically important in taking advantage of those windows of opportunity. And he said that policy entrepreneurs were people who could be in or out of government, in elected or appointed positions, in interest groups or research organizations. But their defining characteristic, much as in the case of a business entrepreneur, is their willingness to invest their resources, time, energy, reputation, and sometimes money in the hope of a future return. In the Chez Soi example that I pointed to earlier, I told you that Senator Kirby had functioned as a policy entrepreneur. I don't actually think that this has to be a single individual. I think that a coalition of advocates and researchers with their combined strengths can also play that role. So I said at the outset of my remarks that Canadian Medicare needs to be continuously made worthy of the wild pride that we have in it. It's not going to be enough to put forward good ideas and just wait for policymakers to pick up on them. And even the most compelling evidence won't gain a toehold in the absence of an alignment of interests. The task before us, it seems to me, in the work to come on Pharmacare or any other great need in the system is to use the skills of both researchers and advocates together to define a single problem in the minds of the public, put forward solutions based on the best available evidence, and look for the window where powerful interests align. We have a lot of work to do, so let's get started. Thank you. I don't, sorry.
I'll shout, because we'll be fine. So thank you very much indeed. So we've got an opportunity for some comments or questions from the audience, because I think the whole idea here is to have some dialogue and debate and see whether, in fact, this agenda going forward of bringing advocacy and research together to affect political change and influence is a way forward. So we're open for questions and comments. I'm sure that you'll have comments and questions, so I'll wait for some someone to raise a hand, and just let us know who you are and where you're from, and then give us your question. So while you're thinking, I'll kick us off. So I think that it's interesting, the Pharmacare issue and these different levels of arguments that can be put forward, the equity issues, the economics issues, and the quality arguments. I mean, I've always thought that makes such a compelling, in a sense, if you've only got one argument for a policy change, that seems weak to me. Whereas if you've got three strong arguments for policy change, then that seems like a better place to be, because you can always fall back on the second one if you get knocked off on the first one. But your argument is actually you'll be in a stronger position if you've really only got one argument for policy change, because it's a simpler sort of case to make. So I'm sort of struggling a bit with, I feel more comfortable with three strong arguments rather than one.
So it's, so I hear you completely, and I agree with you. I think there is a difference between arguments in support of a particular policy and a problem definition, right? And so that's what I'm trying to differentiate here. So, I very recently had the experience of being in a room with some high-level policymakers who work in this area, who you would think would know all of this stuff, and they said to me, "Okay, but really, you say that there are all these people who can't fill their prescriptions and take their medications. Who are those people? Because we think we could just design a program that would help them, and it would be a lot cheaper and a lot easier than implementing all of this other stuff." And so actually, if the thing that we care about, if the problem that we care about is the 1 in 10 who can't fill their prescriptions, you could get at that problem with any number of solutions that don't necessarily look like universal first dollar coverage Pharmacare. And so, the policymakers are going to go there anyway. You give them a problem formulation, they're going to look for options on solutions that actually match that problem formulation. And if we keep trying to shift the problem to match the solution that we like, we lose them. And so it's not that I don't think that the full set of arguments around Pharmacare are compelling. They're very compelling. I agree with you. They're very strong on a whole number of different levels. And as I said last night, it's not that often that the right thing to do is also the cheap thing to do. So, it's very compelling in the case of Pharmacare. But I think that we suffer from a lack of clarity around what the problem is that we're trying to fix. And I think we would probably get better public support and more momentum if we had clarity on that.
You talked quite recently about one solution, which is the idea of picking 10 drugs and having them covered. How does that fit with the problem definition? That's a solution.
Yeah, so the solution that I've been out there peddling in the public sphere, I call it 20 drugs to save a nation. It's essentially, the concept is a limited national formulary that we would all go in terms of coverage across the country as a way of putting in place the institutions and the processes that are required for implementation of full national Pharmacare. The reason that so the way that I formulate the problem, just to kind of run my own solution through the Kingdon model, is I frame it as an equity problem. The problem is that people can't get access to the medications that they need. The solution then is to begin to cover those critically important set of medications, not every single one, perhaps in the first instance, and the implementation is more than cost neutral. So the economic argument is a support. It's a support argument. It's we remove the hindrance or the concern or the barrier that this is going to cost a lot of money by designing it in a way that is cost neutral, because we overpay so much for medications in Canada. But the problem formulation is an equity formulation, because I think that is the one that taps into Canadian values. And I think that's it's my view that it's the formulation that's most compelling. I recognize that others may feel otherwise in the room.
So just sort of building on that. So there's an equity at one level, and then potentially inequity at a different level, because you've got to pick the chronic disease patients who are going to be the winners, and therefore you're defining some chronic disease patients who are going to be losers. So in some ways you could argue that the it's actually going to, there could be it could be more inequitable as a result rather than more equitable.
That's right. No, I completely agree, and which is why I think it's critically, and again, this is the thing about incrementalism versus the Great Leap, right? If you did the 20 drugs to save a nation, and of course it wouldn't really be 20, it might be 50 or 100 or 150, whatever the magic number is. But if you did the 20 drugs to save a nation, I think you could only successfully get alignment of interests and the political stream if it were explicitly a step toward the full meal deal, if you will, right? And the limited nature of that solution, in my view, makes it more politically appetizing because it is a safer start than the Great Leap would be. But I recognize that I'm not necessarily in the majority, in my view, as to whether or not that's the best possible solution. And you've correctly identified one of the core objections to that approach, which is that by necessity, if you're only covering 20 or 50 or 100, then there are quite a few others that aren't getting covered in the first instance. It's just a question of again, what is the shape of the solution that you're going to be able to fit through the policy window of opportunity, and depending on what that window ends up looking like, we'll be able to tailor the proposed solution to meet it.
Great. Yeah.
Discount that they will allow.
Yeah. So it's a thoughtful question, and others in the room may have views on this. I actually have often said that both our current state of pharmaceutical coverage in Canada, two things. Our current state of pharmaceutical coverage in Canada mirrors almost exactly the state for general health insurance in the United States, right? So you have some people who are covered by a VA-style public system. You have some people who are covered because they're seniors or on disability or social assistance. You have the majority who have coverage being covered through private employers, and then you have uninsured and underinsured Canadians. So it's almost exactly the same frame. And in fact, I would say that if you de-Americanize the rhetoric, if you look at the interests and the path dependency that we find ourselves on around pharma coverage, it is not dissimilar at all to the fights that are happening south of the border in an attempt to kind of get some logical, rational approach to healthcare coverage in general. So I'm not sure that the proximity to the US limits us so much in our ability to negotiate better prices on drugs, because I don't think we have remotely tried to, put our collective purchasing power together and actually, put anything out to tender or done anything that we could be doing on improving drug prices. It might be that we would never get to New Zealand levels. I don't think we have to get to New Zealand levels. If we got halfway, we would be, in terrific shape. But I actually think the American debate about health insurance reform more generally is really informative in helping us to understand what we could be doing better or doing differently to try to advance the Pharmacare agenda in Canada. They're virtually identical debates in a lot of ways.
Yeah. Oh, sorry, I didn't see. Yeah.
Oh, hi. I'm Melinda Suter from the Department of Occupational Science and Occupational Therapy at the Faculty of Medicine. I have a process question. First of all, thank you for your presentation, and thank you for a 30-year-old model that looks pretty applicable.
Yeah.
I'm just curious about what you're presenting is really a nonpartisan way. I'm interpreting it as a nonpartisan way to get together to sort of swell our numbers around certain issues. And I think that's really important because as a member of the NDP, I'm just wholly disappointed in the NDP. So I think we need to go beyond the traditional parties. So my question is, do you have any ideas about how to get some of us to think differently around perhaps being in bed with strange bedfellows who we have similar things on one side of the coin, but really would not want to be with, say, Preston Manning? It's sort of a horrible thought, isn't it? Anyway, about process. So is there a way that people can shape their thinking a little bit differently and broaden out?
Yes, no, it's great. And I think, I mean, again, this is why I bring the 30-year-old model, because I have found it really useful in providing some clarity to me, my own thinking on this. If we live in a world of broad, general coalitions that sort of agree on everything, then the list of bedfellows is pretty short for anybody. But if we live in a world of interest alignment on particular problems and particular solutions, then the list of institutions, organizations that one might, or individuals that one might interact with gets a whole lot longer. You know, I was reflecting on this actually in general around the, I'll digress just for a moment because I think it's related and somewhat interesting, the success of organizations like Canadian Doctors for Medicare, which I in my wholly biased way, actually view as a reasonably successful organization. And if you look at in Ontario, medical politics in Ontario was dominated in the 1980s by traditional organized medicine, the Ontario Medical Association, and the only kind of counter voice was the Medical Reform Group, which was a group of progressive physicians that, for example, were objected to the physician strike when Medicare came in the mid-1980s. And the Medical Reform Group viewed health as a fundamentally political and social issue, were very active on a whole broad range of important issues of their time. And I was a member of the Medical Reform Group. I thought they did terrific work, but they never got past 200 members. Like, they just never grew because they had a position on everything. And when you have a position on everything, you're going to alienate a lot of people. So the Medical Reform Group has folded. They officially had their last meeting a number of weeks ago in Toronto, and a lot of the people who came out were real, pioneers actually in the world of progressive medical politics. But that organization exists no more. And does that mean that we no longer have physicians that are advocating around important political issues? No. We have Canadian Doctors for Medicare. We have Health Providers Against Poverty. We have Doctors for Refugee Care. We have Physicians for Global Survival. We have Canadian Association of Physicians for the Environment. We actually have a very long list of activist physician groups in Canada that are doing critically important work on a whole bunch of issues that a group like the Medical Reform Group would traditionally have been involved with. But people like to know what they're signing up for. I think this is true of physicians, but I think it's generally true, in life. And as the world becomes a more specialized place and we see more kind of advocacy on more specific issues via social media, et cetera, that becomes even more the case. And so I'm not saying that there isn't still a place for broad advocacy groups, but I do think that the success of more narrow issue-based advocacy groups in healthcare and elsewhere reflects this trend, that you can get people on board when you are clear and specific and particular. And I will collaborate with anybody who wants to see national pharmacare implemented. And I don't need to have a beer with them afterwards, right? Yeah.
And when I first got there, I thought, I won't be able to get the drugs that I need for this, that, and the other thing. And it turned out not to be true. Only once in 10 years I had an issue. And I wonder, I'm trying to think of a parallel here. Telephone plans comes to mind. Where you spend hours agonizing, Telus, Rogers, those extra daytime minutes. The bureaucracy spent implementing all these little sideline fixes outweighs any good that we can do.
Yeah, those are terrific observations, and I agree with that assessment of the risks. I mean, on this question of choice, the AARP did a study a number of years ago around the ability of seniors to be able to actually effectively choose between insurance plans in the United States. I mean, nobody can understand that stuff, right? And so people sign up for whatever looks like the default or whatever their friend has signed up for. This notion of an informed choice consumer in the world of healthcare insurance is completely bogus. The asymmetry of information is so great. It is not possible to expect an individual human being. So I think we actually have to frame this choice question not as being about being able to choose between your two completely bioequivalent statins, one of which costs 60 times more than the other, or you're choosing between your two different insurance plans, each of which has reams of footnotes that nobody, written in legalese that nobody can understand, but rather choice around the things that people really care about, which is their own treatment and their own health, their own ability to have a conversation with their healthcare provider about what matters to them, what the goals of treatment should be, and a lack of impediment to getting those, to implementing those choices around their own health, particularly lack of financial impediment in terms of out-of-pocket spending, co-pays, deductibles, and all of that kind of thing. So that is where I would like to see the choice conversation go. I remember reading a quote once from somebody in the UK who said, people don't want choice in their fire stations. They just want someone to show up when their house is on fire, right? And so I think that this choice thing can really be very overblown, and we need to think about how do you have transparency in the process so that there is a feeling of engagement in the choices that get made, but not snow people with a whole bunch of stuff that they can't possibly be expected to choose between. And I don't think that is paternalistic. I think it is real.
So we wouldn't have said fire station, we'd have said fire brigade.
Right.
A small point.
Fair enough.
I've got time for one more question, I'm afraid, so you get the last question. Thank you.
Okay, so it's a good question, and I'm afraid I don't know the details of the antiretroviral story in BC. I will say that, one of the great examples of all time around access to essential medications, of course, was the work of Doctors Without Borders, MSF, with respect to access to retroviral medication in sub-Saharan Africa. So, I think this is a movement that has been extremely effective globally, and not just here. And we have someone here, Alison Lawton from Access Our Medicines, and those of you who haven't seen their website should go and check it out. It's, this is a global problem. It is not just a Canadian problem, and I think we can learn from some of the work that's being done internationally and globally, as well as here at home. I will say that there's the antiretroviral example, and of course in every province there are examples around cancer. Some places where it's been handled more effectively than others, my own home province, Ontario, being an example of where it's being handled extremely poorly. So I think that there are lots of examples that we can draw on. And, I'm not married to the Kingdom policy framework. I just like it as a way of trying to understand and break it down a little bit, analyze why some things have worked and others have not. I'll put in a final plug that several of the sponsoring organizations have put materials out and things that people can take home and sign up for and whatnot. So I'll encourage you all to take a look at that on your way out the door. And I really appreciate the invitation today. So thank you. I hope it was interesting for you.